So we know Dr. Binayak Sinha is a consultant diabetologist at University Hospital, Birmingham. He has his fellowship in the member at the Royal College of Physicians, UK. He has a special interest in PCO, and he is co-author of many books. And we are eager to listen to him about his talk on the GLPA versus GLPA versus the SGLT2. Your audience is yours, sir.
Good evening, everybody. I think, Hardik, you'll have to let me share the screen. So while Hardik is letting me share the screen, let me just correct my topic. My topic today is not SGLT2 versus GLP1. My topic today is talking about NAFLD, GLP1RA, and SGLT2 inhibitors. So that is what I will be talking about. And this actually comes on beautifully to addressing more of a cardiorenal metabolic outcome that we are more interested in, rather than just trying to find out what kind of a glycemic control we can achieve for our patients. So can I share the screen now?
I really apologize because earlier I spoke about Sojoy, so I just mix up with your talk. I'm sorry for that.
Yeah. Not at all, not at all. So I'll be talking about this. This is my talk, and Nandita very nicely put across what we are doing about cardiovascular disease and showing the data that central obesity is probably the driving factor for increasing cardiovascular disease, and what we as a generation of physicians are trying to do to improve the outcomes in cardiovascular disease, which are the main slayers of people with type 2 diabetes. But while we were watching this type 2 diabetes and this epidemic of cardiovascular disease and cardiovascular outcomes, I'd like you to pay a little bit of attention to this slide that I will show you right now. So this is the death rate from NAFLD. So NAFLD is not a benign condition. And if you look at it from time 2007 to 2016, this beautiful paper shows that there has been a 1.5 times increased risk of death from non-alcoholic fatty liver disease, which, as we know, is related to diabetes. It is plateaued in males, but it continues to rise in females. So it is also of high significance, particularly in keeping with the cardiometabolic and renal outcomes that we see. And the main cause of death in these patients are the contributory causes of diabetes, hypertension, and cardiovascular disease. These three are the main driving factor of all the rates of death in patients who develop non-alcoholic fatty liver disease. Not only that, we have publications which show very clearly that NAFLD is associated with increased risk of cardiovascular events in type 2 diabetes, and also an increased risk of microvascular complications like CKD and proliferative diabetic retinopathy that we see. So it seems that both these conditions seem to be driving each other, because not only that, the Verona diabetes study showed that liver cirrhosis counted for the maximum number of deaths above cardiovascular disease in patients who had diabetes. This, of course, is a dated paper from 1998. But in recent times, we've had papers which have shown that in patients with NAFLD, diabetes and aminotransferase levels are independent predictors of severe fibrosis. And there is also strong association between diabetes and the increased risk of hepatocellular cancer in both males and females. So we realize now that diabetes and NAFLD frequently coexist, and they synergistically seem to worsen the outcomes in each situation. So if you have diabetes, the outcomes of NAFLD is worse. And if you have NAFLD, the outcomes of diabetes are also worse, which is why we need to look into a little bit of detail of what NAFLD is. And it is considered to be the liver part of the metabolic syndrome, driven by the same problem that Nandita spoke about a little while back, central or visceral obesity with type 2 diabetes and dyslipidemia conspiring together, leading to NAFLD, which is a hepatic consequence of the metabolic syndrome, with the liver fat content being directly proportional to the number of components of the metabolic syndrome that we can see. In addition, we know for a fact that weight loss improves NASH. As you can see, this beautiful paper, which was published in 2015, wherein good diet and exercise led to regression as well as stabilization and prevented worsening of NASH liver fibrosis. But the treatment of this condition is still not very well recognized. The treatment is not very well addressed. And we as physicians seem to be very happy to be prescribing something known as ADCA, which is sold in various forms like Udiliv and Ursicol and things like that, and have no benefit which has been seen in clinical trials. But the indications are not well established, and pharmacological therapy is used only in patients who have already developed fatty liver with hepatitis to accompany it. The things that come to mind is obviously to look at the anti-hyperglycemic treatments that we have, and the main thing that we use today is metformin. Though metformin improves the insulin sensitivity, it has no effect on transaminases, steatosis, inflammation, and fibrosis, and it is definitely not recommended for use in non-diabetics with NASH. The maximum amount of data has been generated with Pioglitazone, which definitely in this meta-analysis of the multiple trials that have been done between 2006 and 2010 shows that Pioglitazone improves liver fat ballooning, the fibrosis, improves lobular inflammation, and reduces steatosis. As you can see, all the diamonds seem to be falling to the right of unity, showing that there's a favorable response of thiazolidinediones to fatty liver disease. But is pioglitazone something that we are comfortable with using? And I think we have recently published this in Nature, assessing the need for pioglitazone in treatment of patients with diabetes. And I think we have very convincingly shown today that the positive effects are completely offset by the harm they seem to be causing by way of heart failure, fractures, and anemia. This is a risk-benefit analysis that we have conducted, and we have finally come to the conclusion that pioglitazone should therefore be reserved for treatment with type 2 diabetes in patients with established cardiovascular disease, only in patients where other antidiabetics cannot be used routinely. And this is something that we need to stress upon because we are moving away from glucose centricity. And this argument that pioglitazone reduces blood sugar is something that has to fall by the wayside. We really need to take into consideration the toxic effects of this drug and probably use it in very few situations that are available to us as clinicians today. So we come to what is most important, which is body weight reduction. And as was shown by my previous speaker, there is a significant and a massive reduction in body weight with all GLP-1 receptor agonists, including exenatide, liraglutide, lixisenatide, dulaglutide, whatever, name it. They all cause statistically highly significant 4 to 5 kilograms, which is roughly translates into 4 to 5% weight loss. It also works by reducing glucagon and increasing insulin, improving glucose uptake in the skeletal muscle. It works on the liver through multiple mechanisms. The increased insulin and reduced glucagon lowers the triglyceride levels and improves the VLDL and the LDL. The reduction of glucagon and improvement of insulin lowers leptin and increases adiponectin. These in turn work on reducing fat mass, reducing lipolysis, and reducing fatty acids and gluconeogenesis precursors. The gluconeogenesis reduction reduces glucose production and reduces glucose, and GLP-1 RA work on the PPAR gamma, PPAR alpha, and AMPK receptors, uptitrating them and leading to reduced inflammation, reduced apoptosis, and increased tissue modeling. So all in all, mechanistically, there are many ways in which GLP-1 RA work on the liver to improve fatty liver and improving the outcomes of fatty liver disease. And in this randomized controlled trial with liver biopsy is, of course, as you know, the gold standard for any kind of treatment and management of NASH or NAFLD. Unfortunately, it is very difficult to do, and it is not a practicable thing to do. So very few studies are done with this. But this study with liraglutide is actually quite seminal in the sense they did 52 patients liver biopsy. In patients with NASH and NAFLD, and in patients who were obese, they found that there was a statistically significant reduction of body weight, but no improvement of transaminases. But there was an improvement in NASH resolution, which was seen in 9 out of 23 patients who used 1.8 milligrams of liraglutide when compared to placebo. I'll just summarize the findings of the LEAN study, which showed reduction of non-alcoholic steatohepatitis in 40% of the patients, which was statistically significant. It improved steatosis in 80%. It improved hepatic ballooning in 60%, and improved the worsening fibrosis score in about 10% of patients. And all these findings were statistically significant. Now, you may complain that the study is small with just 50 patients, but you have to remember that liver biopsy studies are all of this kind of size and this kind of sample size. And it is not possible to do anything more. So this is a very good idea about what it does to NASH. And I think liraglutide has definitely shown a massive improvement in outcomes of NASH. We've also got a paper from our own country, from Dr. Ambrish Mittal's group. 52% of patients out here, liver fat was studied through MRI-PDFF, and this showed a statistically significant reduction of liver fat content and a relative change of 26.44% of reduction of liver fat, which is a 2.6-fold greater reduction with the usage of dulaglutide. And this also improved the gamma GT levels, but did not seem to be having any kind of effect on the AST or on the ALT. This is a recent paper which the group from Delhi published in July. And also we have data from semaglutide, which shows that the ALT reduction is achieved by increasing doses of semaglutide. There is no liver biopsy data yet, but I know there are lots of clinical trials which are in the pipeline, which are addressing all these things, including liver biopsy data, which should be out with semaglutide very soon. So the potential benefits of GLP-1 RA, as you can imagine, in patients who have obesity, diabetes, dyslipidemia, and hypertension, we find GLP-1 RA reducing inflammation, causing weight loss, improving glucose metabolism, and improving lipid metabolism, which not only leads to cardiovascular risk reduction, it reduces hepatic ballooning, it reduces hepatic steatosis, and in fact has been found to improve NASH to the extent that NASH seems to resolve completely. We come to the gliflozins, and I show representative data with empagliflozin. All the gliflozins have similar data, again about 2 to 3 kilograms, translating into 5% of body weight loss, with monotherapy, with metformin, with other drugs as well that you see with all SGLT2 inhibitors. And all these translate into reduction of hyperglycemia and reduction of visceral adiposity. We know from data that we have that the weight loss is not just water, it is a reduction of visceral adiposity, which in turn reduces oxidative stress and inflammation and increased serum adiponectin levels. And all these conspire to get together and improve the outcomes of Nafld and NASH. And this is basically the putative mechanism by which they seem to be working. The effects on liver biopsy, these are liver biopsy in animal models. As you can see, all of them, IPRA, REMO, Lucio, canagliflozin, empagliflozin, tofagliflozin, all of them have been studied in rats and mice, and they seem to be improving hepatic steatosis and hepatic fibrosis. And indeed, tofagliflozin shows a reduction in hepatocellular carcinoma in mice on liver biopsy studies. These are all experimental models. So naturally, they provide a very attractive strategy. Not only do they reduce fat, they reduce visceral fat and improved outcomes in animal models. They seem to be a very attractive strategy for the management of NAFLD. And this has again been studied by the Delhi group, Dr. Ambrish Mittal's group, which again shows a reduction of liver fat. As you can see, there's a statistically highly significant reduction of liver fat measured by MRI, which is with treatment empagliflozin. However, there is no liver biopsy data as of now, and though these drugs act by reducing renal glucose reabsorption, causing calorie loss and weight loss and loss of fat mass, improvement of animal models, there has been only one small meta-analysis to date, which is decreased in liver fat and improvement in ALT, accompanied by weight loss, with no impact of SGLT2 inhibitors on glycemic control. This is a Chinese study which was done. With this in mind, we actually came up with this recent publication in Journal of Gastroenterology and Hepatology This is a meta-analysis of the effects of sodium glucose SGLT2 inhibitors in non-alcoholic fatty liver disease with type 2 diabetes. Large meta-analysis, as you can see, about 12,000 patients with 7,000 on SGLT2 and 4,000 on the control arm. Now, this control arm, you have to take into consideration, this is a bit restricted because we only took drugs which do not have any effect on liver function. For example, we did not take any comparative data with metformin or say a glitazone or a gliptin or a GLP-1 RA. It was just against placebo. So this is a complete, I think this is kosher data showing just the effect of SGLT2 inhibitors versus placebo. And as you can see, there is a statistically highly significant improvement of all the transaminases, which is persuasive p-value of less than 0.01. Though the results are heterogeneous, there is a very highly significant result that we see in the improvement of transaminases, indicating a reduction of inflammation, which, as we know, is a driving force for NFLD. Measurements of liver fat and visceral fat are also improved by SGLT2 inhibitors, statistically highly significant again. And out here, we have no heterogeneity with improvement in all across the board, which are, again, have highly persuasive p-values. Again, we look at the weight. Weight, not surprisingly, is reduced with SGLT2 inhibitors, and HbA1c also is reduced. And this is what you would expect with SGLT2 inhibitors, though triglyceride levels did not reach statistical significance. So this is the findings which led us to conclude that SGLT2s have a salutary effect on NFLD. This is showing up in reduction of hepatic inflammation and reduction of hepatic steatosis. And this is probably driven by an improvement of glycemia and body weight, which is attenuating the hepatic inflammation and hepatic fat accumulation. So I will conclude this session by showing you a summary. The NFLD NASH frequently coexist with type 2 diabetes, each worsening outcomes for the other synergistically. There is weight loss with SGLT2 and GLP-4 inhibitors, which is needed for management of NFLD and NASH. Thus, they present an attractive strategy for the treatment of type 2 diabetes and NFLD. Liraglutide has been shown to improve liver biopsy outcomes. There is benefit seen with other GLP-1 RA. And the recent meta-analysis that we have published has shown that SGLT2 inhibitors provide a marked improvement in inflammation and liver fat, probably mediated by weight reduction and improvement of HbA1c. And we would expect that publication of this and further RCTs will actually lead to treatment changes in the treatment algorithm. And as Nandita showed you, this is what the present ADA-EASD algorithm looks like. Hopefully, with publications like that we've shown you today, in the near future, we will have another separate box for NFLD, where the first line drug will be SGLT2 inhibitor or GLP-1 RA. Thank you very much for